is kind of intense in the sim clinic because we look at angulations, and me and our 2 residents will be working intensively with you. So we do half the class this week and half the class next week. So if you look at your axiom, or not axiom, what's it called? Canvas, thank you. There's actually a typo. It says group 2 and then group 2 again next week. It's group 1 this week and group 2 next week. So group 1 is Mina. Where are you, Mina? That's okay. I never came to class either when I was there. I didn't, and I'm just telling you the truth. I didn't. That's why I don't grade for attendance. I don't. Until Buniel Kim. And then group 2 is Ashley through Wenzo. So if you have like a wedding or something else and it causes you to be assigned to group 1 and you need to go with group 2, it's okay, you can do that, that's fine. The point is I wanted to keep the numbers about half and half so that between me and the 2 residents, you get the attention you need. Any questions?
So just group 1 on Friday, group 2 does not attend?
Right. So just group 1, so that's Mina through Buniel. And then next week, it's Ashley through Wen.
Okay, so on Canvas, the schedule, it says, should we just like disregard because it says scaling and training this Friday and then oral hygiene communication next Friday? So is that
I think you're off by a week.
it says scaling and training the next one. Oh, that's a week off. Oh, sorry, my bad.
So have you heard anything about my reviews for the exam? Now for this class. Have you heard?
Participating.
Yeah, I brought my questions.
So the more you participate, the more you learn. When it comes to my exam, I'm never going to trick you, ever. I'm not here to trick you. Trust me, I remember those so-and-sos when I was a dental student like you. I didn't like them then, and I still don't like them now. Like really, like you got to prove who you are by like tricking a bunch of students. Give me a break. Get a life. Really, that's how I see it. So I'm not trying to trick you, but I do ask that you know what I need you to know. I think that's fair, okay? That means you have to study, you have to know what makes you safe. What if that's my family member sitting in your chair? I want to know that you're good at doing what you're doing. And if that means every single person in this class remediates, and if that means every single person in this class gets 100, I don't care. What I want to know is that you're safe with your patient. Very good? So let's start. Please do participate. So the attached gingiva is part of the keratinized tissue between what and what? Say it louder because you're right.
Alveolar mucosa and free gingiva.
Very good. Did everybody hear? Say it loud. Be confident and proud because you're right.
Alveolar mucosa and free gingiva.
Now did everybody hear? Get up and yell it back there.
Alveolar mucosa and free gingiva.
I do respect the confidence. So, okay, so we said attached gingiva then is between the alveolar mucosa and the free gingiva. But what are the exact landmarks which differentiate between the attached gingiva and the alveolar mucosa? What's that demarcation line called? Very good, mucogingival junction. And how about the exact dividing line between the free gingiva and the attached gingiva? What's that sucker called? Free gingival groove. Very good. Now, I know you guys hate histology. That's okay. You're allowed to have your opinions. What is this thing? It totally looks like a puppy. Look at this. Are you videoing me? I look terrible.
I'm audio recording.
Oh, and look at this. Here. There. My leather stuck to the seat.
It's pointed
Tape
down
that.
because you said you didn't want to. be recorded, video.
Well, then let's let the whole leather stick to the seat if it's going to stick. You can tape that. Yes, ma'am. Yeah. Okay, so the question is, why can't you say CEJ for that? Why is the CEJ not a dividing line of the attached gingiva? Why is it not the CEJ? Because the gingiva ends before the CEJ starts, right? And the CEJ is a demarcation line on hard tissue, and we're talking about soft tissue. There's lots of demarcation lines, and really I think the best way to learn this is to draw it. And I showed you the same slide, and Basada showed you the same slide. I showed it in the sim clinic, and he showed it, I think, in his first lecture. Right? If you know how to draw that in your brain, or if you can just close your eyes and see it in your brain, you can answer that type of question. Okay, what's an interdental coal?
Like between and proximal surfaces where the gingiva come up and then kind of scoop down, it becomes.
Did everyone hear her?
No.
Ashley, I know you have confidence.
Okay, so it's in the interproximal space between the teeth where the gingiva come up and there are kind of two peaks on the facial lingual, and then it's a little scoop down around the contact point.
So what's that little scoop? How do you describe that? Saddle. Right? And now it helps me, if you're not a drawer, and it still helps me, to remember things the way Dr. Basada says them. Saddle shaped. It helps. Okay? So now, Ashley, you described the two ends of the saddle, right? You described them as the lingual and the facial. But the lingual and the facial what? Papilla. Very good. Okay, the presence or absence of an interdental coal depends on what? Contact point. Very good. In which of the following anatomic locations is epithelium not keratinized? So now I have to think of that drawing again. Okay, let's do it this way. Let's do it because I heard the answer already. So let's do it a different way. Free gingiva. Is it keratinized or not? Keratinized. Alveolar mucosa, keratinized or not? Not. Attached gingiva, keratinized or not? Interdental papilla, keratinized or not? Okay. Earliest signs of chronic gingivitis. What are the earliest signs of chronic gingivitis? Okay, I heard rolled papilla. Change in color. Okay, so what's the sign of inflammation?
Redness.
Okay, we said change in color already. Bleeding on probing. Very good. Okay, so let me ask you then, what are not signs? What are not the earliest clinical signs of chronic gingivitis? Pain. How about mobility?
No.
No, okay. How about pocket formation?
Yes.
Ooh, we have a debate.
Not gingivitis. I think it's very detached.
So you have to have the swelling and the inflammation to attack the pocket, and then the pocket will decrease. So the inflammation is the trigger.
So those of you who are in the camp that says the earliest sign of gingivitis is pocket depth, Ashley's got words for you.
They're polite words.
Why? Why can't we have a debate? This could be fun.
So the inflammation is what causes the loss of pocket depth, or the increase in pocket depth and the loss of attachment. So you have to have the other things first before the pocket will extend.
Does it make sense for everyone?
Yeah. So you have to have the inflammation and the loss of attachment before the pocket will increase. So the earliest sign is the inflammation and things like that that cause the loss of attachment.
But let's say, what are the things like that?
Oh, so like the swelling, the redness, the rolled margins, and the other ones that we just listed.
And the most important one,
Bleeding.
bleeding on probing. Very good. Okay.
So it's pain,
Argination.
Those, right, those are the knots. Well, there's a lot of others. I mean, you can think a lot of things that are knots, right? Okay, all of the following are classified as lining oral mucosa. What are lining oral mucosa? Okay. How about the soft palate? Is that lining oral mucosa? How many say yes? Hands high, confidence. And how many say no? Let's have a war. Now, those of you who say yes, why yes? Why is the soft palate lining oral mucosa? Because it's not specialized. Very good. How about alveolar mucosa? Is that lining oral mucosa?
Yes.
Yes? Anybody in the no camp? Look at me. I'm all starting problems today. How about the dorsal surface of the tongue?
Specialized.
Specialized. How about the ventral surface of the tongue? Okay, very good. Oh, fibers. Did you guys enjoy learning about the fibers?
Like Sharpies or like PDO?
Oh, look at you. You want to know which fibers? Look at you. All right, then let's talk about PDL fibers. So, what are those principal fibers of the periodontal ligament made of? Are they elastic fibers? Ooh, debate. Are they collagen? Okay, it seems you agree on collagen. All right. Are they straight or wavy? So you should know whether they're elastic or collagen, and you should know whether they're straight or wavy. Okay, so there's 3 ways. Who brought up CEJ? You did. Yep. So let's talk more about the CEJ, since it already came up. What are the 3 types of CEJ presentations you can have? So I'm seeing it because you guys are doing it with your hands, right? So there's this kind. What is this? Okay. And then there's this kind. What's that? Okay. And what's in the opening? Dentin. Okay. And what's the third one? Overlap. So who's overlapping who? Okay. And what's the most common of these? The overlap one. Okay. The oblique fibers of the periodontal ligament, because you asked. The oblique fibers of the periodontal ligament are inserted in the alveolar bone, higher or lower than those in the cementum. Again, I know you guys hate histology, but if you draw the picture, you'll know it forever. Thank you for agreeing with me. No one likes histology except, I think, me. Even the residents, you guys hate histology, right?
I think histology hates us.
Aww, no. But that is the best way to say it. That's awesome. Okay, so you guys wanted to talk about Sharpie's fibers, or at least you did. Let's talk then about Sharpie's fibers. Bundle bone is part of the alveolar bone proper, where what is present? Sharpie's fibers. So somebody want to describe that to me? What is bundle bone? Somebody want to explain to me what bundle bone has to do with Sharpie's fibers? This corner of the room has has it. I think they're like being nice so that other people can talk. You don't have to be nice.
Thunderbone is where the Sharpie fibers invade.
Yep. Did everybody hear that? Can you say it louder?
Thunderbone is where the Sharpie's fibers invade.
Invade's probably not the word, but let's
Well,
go with are present.
The way that Dr. Sally explained it was, as that bone is being laid down, so essentially it's coming together.
Right. Exactly.
It fuses into it.
Right.
As it goes
They're
up
in
and
there. Right. But invade sounds. Yeah, it sounds malignant. It sounds mean. The width of the PDL space is what? 0.25. I mean, if you're going to remember a number in this class, 25 is a good number to remember, right? It's thumbnail blanching. It's 0.25 is the PDL, right? And what is the shape of the PDL space around a root? Like a Coca-Cola bottle. The presence of pink, of gingiva, always indicates that the periodontium is healthy. Why? Why no?
In advanced disease, it actually will start to pink up again under
Right.
the influence of fibrosis.
Because fibrosis is also pink. And just so you guys, as you prepare for boards, anytime you see that word always, remember we had a huge conversation about range? Remember? And we throw range at you all the time, even when you have to deal with PCCs, because they're all different. There's a range. Okay. So when you see the word always in a question, your like antenna should go up. In a healthy periodontium, the color of gingiva is more red, less red, or the same red as the alveolar mucosa. Why? Yeah, you're right. Why is the alveolar mucosa more red? Right, so why is then the alveolar mucosa more red? We agree.
Vascularized?
No, you had it the first time. Let me ask it again, because I feel like I lost you guys. All right. The color of a healthy periodontium, we're comparing the gingiva to the alveolar mucosa. Which is more red? Then which is more pink? Why? And what does the keratinization do? Is keratin colored?
Should be white.
It should be white. So what's white and red? Good. Good. And that color mixing question, it becomes more relevant as you talk about fibrosis. And when you get to being a resident and you start to do root coverage surgery and you start to look into a patient's history, and maybe they won't tell you their whole history, you start to see different levels of keratinization and have to read into those color changes like a painter looking at an artwork to see what color was used and trying to match it or something, to identify whether this was a surgical intervention that caused this or whether this is a natural intervention or a disease process. So even though that sounds like a kind of an irrelevant, kind of hokey question, it becomes very, very relevant once you get to surgical therapy. Okay, so the three ways that the CEJ come together. And you said the most common is the overlap one, right? What percentage is that? I could buy that. How about the sulcus? The gingival sulcus is bounded by the surface of the tooth on one side, right? And what on the other side? Say it, you're right.
The junctional epithelium.
So epithelial lining, right? Because the junction epithelium is at the bottom of the pocket, but I'm talking about the walls of the pocket. So imagine you're sitting in the sulcus on the mesiofacial of number 8? You're sitting in that sulcus. And you look one way, and there's the tooth. And you look that way, and what's on the other side of you? Epithelial lining. And, well, let's say you're standing in the sulcus. What's under your feet? There is your junctional epithelium. Okay. So when you put the probe in, you're not standing in it, right? But on one side of the probe, you have the tooth. On the other side, you have, right? And what stops your probe? Junctional epithelium. Now, why does nothing stop your probe when you're up in the sim clinic? Right. They also don't have blood or spit, or they're like not fun. They don't talk. They don't complain. Okay, so we talked about getting pinker after fibrosis, right? So let's talk then about tissue destruction. Tissue destruction and repair, do they take place at the same time in untreated chronic gingivitis?
No, the repair mechanisms are actually, to some degree, attenuated down.
Okay, so if they're attenuated in, can't you have them both happening at the same time?
I mean, to some degree, yes.
Yes. Yes, you can. Does anyone want to argue with him? No one wants to argue?
The damage is more than-
I can't create any fun. He's sitting here cracking his knuckles, ready to take on anybody.
That's it.
Uh-huh. I guess that did it.
I'm like the least violent person I know.
You're scary apparently. You got the knuckles cracking. I'm kidding. I'm playing. You have to, okay? It's a dry subject. Okay, so when you have then concurrently destroyed and repaired tissue, does that have an effect on the color and the form of the gingiva? Right, we said yes, right? Because of fibrotic appearance. Okay, so in periodontitis versus gingivitis. Periodontitis versus gingivitis. The distance between the alveolar bone and the CEJ is the same or different? Different. Okay, and which one is a greater distance from the alveolar bone to the CEJ? Periodontitis or gingivitis? Okay, why? Bone loss. Thank you very much. Okay, so alveolar bone has blood vessels, yes or no?
Yes.
Okay, does it have nerves?
Yes.
Okay, cementum, does it have blood vessels? Does it have nerves? What? Debate. Resonance. I will let you look it up. You said it, but I don't. But there was enough argument that I think that they should look it
So
up.
it's the new information.
Let them look it up.
Because the pub has the nerve tissue, so it's separate from. Sorry, I thought we were supposed to discuss.
Ashley knows the answer, you guys. And she's right. But I do think it's worth looking it up because, again, in oral path, you're going to get primary cementum versus secondary cementum, and it's worth a primer to read it. So you'll learn the difference between primary and secondary cementum. Okay, the earliest sign of chronic periodontitis, because we talked about the earliest sign of gingivitis. Now, what's the earliest sign of chronic periodontitis?
Increased pocket depth.
Is it increased pocket? Can we have increased pocket depth in gingivitis? Ooh, debate. Yes, you can, right? Remember we said that if you hit your thumb with a hammer, it swells, right? Same way, if you have swelling, you can have a deep pocket depth. So what's one of the first clinical signs of periodontitis then? bone loss. Thank you very much. How about the earliest radiographic sign? What is that bone loss going to look like? Is it going to look like,
Radiolucency.
okay, but the earliest sign, even before you get that big cupped out radiolucency? I don't love this question. And if more than 50% of you miss any question, I throw it out. Yeah, so you can agree to hate.
So we miss them all.
Right. Go miss. Well, no. If you miss them all, then we all remediate. I already said that.
Guys, one question.
That's it. Did everyone hear? Can you say it again?
The crestal lamina dura,
Now, what is a crestal lamina dura?
it's more opaque. And when you look at the radiograph.
Right. So it looks like a little whiter than the rest line. And that's, I think, Bisada's second lecture or first? It was today? Oh, he mixes things up, doesn't he? Stinker. All right, so just another aside about crestal lamina dura, since you hate histology. I mean, it won't be on the test. I just want you to kind of get an understanding of lamina dura since you just did it today. If you were to take bone, like if I were to like walk up to Jacob and like put like a forceps and rip off a tuberosity and look at it under a microscope, would I see histologically our lamina dura? Very good. You would not. It's not a histologic existing thing. It's only a radiographic thing. And that's not a test question, but you should understand that. The pattern of bone loss in chronic periodontitis. So we agree that the lamina dura goes first. What goes next? Horizontal, vertical, combination, no rules. Let's take a vote. How many say horizontal? How many say vertical? How many say combination?
Well,
How many say no rules? Residents, what do you guys like?
Mostly horizontal. Some vertical.
I was certain you'd say no rules. So it can be any of the above. There's no rules.
Rules?
No rules. I was totally counting on you guys to be like, no rules. I love no rules. Another just aside, when it comes to humans, no rules is usually a good answer. Just, when it comes to things. When the base of the pocket is apical to the crest of the alveolar bone, is that called an infrabony or suprabony pocket? When the base of the pocket is apical to the alveolar bone, infrabony or suprabony? Infra, very good. Okay, and in that situation, where the base of the pocket is apical to the crestal bone, is that a horizontal bone loss or a vertical bone loss? Vertical, very good. So we talked about early signs of periodontitis, and then we talked about what are not early signs. We said there's a lot of things that aren't early signs, right? So how about tooth mobility? Early sign, middle sign, or late sign? Okay. How about a patient that comes in and says, my teeth are just migrating for no reason? I swear my midline was over here and now it's moving over here. Early, middle, or late periodontitis? Late.
What's the difference between tooth mobility and tooth migration?
What's the difference between mobility and migration, residents? I just went to visit Jack Caton last week with his jiggling forces. and squirrel monkeys. He didn't introduce me to any squirrel monkeys, though. I would have taken them home. I would have brought them back for you.
Migration should be adapt prudential, mobility with number.
There you go.
What?
So mobility is with an intact periodontium. No, the other way.
Migrations.
Migration is with an intact periodontium. Both ways, though, your support structures are lessened, so it's late. It's a late sign of advanced periodontitis, not an early sign. Okay, plaque-induced gingivitis is the only recognized form of chronic gingivitis. I think he said that today, didn't he? So plaque-induced gingivitis is the only kind of chronic gingivitis. False. What are other kinds? Diffuse, marginal. How about chronic gingivitis can be marginal, or what else? Because he told you it could be marginal, and that means along the margin. So what else could it be? What else could it be? Okay, so it would be diffuse across the attached gingiva. What if it's only on the papilla? See, I feel like when he described it, sometimes he goes into a lot of detail. When you listen to the weather report, and they say there's a marginal chance of rain, they mean it might rain and it might not rain, right? But when we say marginal periodontitis, we mean it's not a little bit of perio, it might have a little and a little not. We mean periodontitis along the margins, which could also mean papillary, right, on the papilla, or diffuse across the alveolar mucosa. Does it make sense? So in perio, we speak kind of a different language than everybody else. So make sure when you take the exam, you're speaking perio. So in gingivitis, the pocket epithelium is friable. And then when you probe it, what happens? It bleeds. Very good. The pathway of inflammation from the gingiva to the deeper structures follows the course of blood vessels directly and mainly to which of the following deeper structures? You want to hear that again? The pathway of inflammation from the gingiva to the deeper periodontal structures follows the course of blood vessels directly and mainly to which of the following structures? So it goes from the gingiva to what? Inflammation travels from gingiva to what? To PDL, and then to what? Bone. So in this question, it's asking you the deepest structure. So let's be clear. When we say directly and mainly, you might think that it's the next tissue in progression. But this question is not asking you the next tissue in progression. Mainly and directly means to the very last structure. Is that clear? I don't think that's worded fairly, so I'm trying to be as transparent as I can and not trick you in the words. When the pocket is the result of gingival enlargement rather than apical displacement of the sulcus, we call it a periodontal pocket. So there's two kinds of pockets, right? But when the pocket is a result of apical displacement of the base of the pocket, we call that a periodontal pocket or a gingival pocket? Periodontal pocket, right. So a gingival pocket then would be just from inflamed gingiva, not from the apical migration of the base of the pocket. Got both of them? Yeah, that would be a gingival pocket. But a periodontal pocket is the apical migration of the base. Right? Because it's apically migrating into bone, and bone loss is the hallmark of periodontitis. In the later stages of chronic inflammation of the gingiva, this is what like this side of the class wants to talk about, where fibrosis has occurred, do we get stippling or do we not get stippling? Does stippling return in fibrotic gingiva? Residents, does stippling return in fibrotic gingiva? It does. Stippling does return in fibrotic gingiva. Okay, and let's say the stippled area. The area of stippling has a higher or lower metabolic rate than its neighboring area. Not you guys, just the residents. Don't you guys worry about that. That's for them. Which bacteria are most likely to be isolated from a lesion? So in my question, I'm not going to say a periodontal lesion. I'm just going to say a lesion. Because this is perio, and I expect you to just kind of know that I'm talking about a perio lesion.
Is that the denticola gingivalis, or is that something?
So it could be a forsythia, right? What would it not be? If it's a lesion, then what bacteria would not be there? And if it's a lesion, you want bad bugs, right? So we started to talk about our bad bugs. It's a T. forsythia, denticola, right? Gingivalis. What other bad bugs are they? How about, let's talk about shapes. What are the shapes of bad bugs that would be involved in a lesion? Bacillus. Okay, what else? I heard it over here. Spirochetes, right? Spirochetes are bad bugs. Okay, what are the shape of not bad bugs that would not be in a lesion? Cocci, right? So if it's a lesion, you're looking for bad bugs. Okay, what are the really bad bugs? Let's go through it one more time. P. gingivalis, T. forsythia, T. denticola. So if it's not one of those, it's probably not a bad bug, right? Right? All right. Be clear on that. What percentage of Americans, according to the CDC slide that I showed you, suffer from gum disease? Okay. So it is close to 50, right?
47.
Look at you. It is 47, yes. It's 47.2.
Was there like some sort of detail where it was like, this is the estimate, but there's something more with undetected, or like 47% is the undetected amount? And so then was there a different stat for like diagnosed?
So I think there's a source of error in the study. So, and because of the source of error, we say about half of the people running around have gum disease that you guys have to find.
Okay.
But for the exam, I love that you guys knew that it was 47.2. I love that. Look, if you had it in your head close to 50, you'd probably get the question right. But I'm like so thrilled that you guys have 47.2. And you know the ideal probing force, what's that? Okay, which can also be called? Very good. And it needs to be the same between me and where's Keith? Right.
Hey, we have winners with the Asta Flex, all three of them in this room.
Oh my gosh, that's so awesome. That's
Yeah, keep it up, Joel. Good job, guys.
and yet you guys like don't want to pick a fight with each other. There's so much strength in this room, and yet you guys want to work together. I like that. Good. Smoking increases or decreases bleeding on probing?
Decreases.
Why? Vasoconstriction. Okay, so we talked about virulence factors of the bad bugs. What are the virulence factors of them bad bugs? Motility. And how about spirochetes? Are they motile? Yeah. They kind of, right? What's your question?
If staying in the biotone is advantageous, why would you want motility? why would you ever want to leave the complex if the complex is essentially what's you're deriving your nutrients from that, especially if you're asaccharlytic.
To invade, using your word. So spirochetes and some of the other bacteria are able to penetrate and invade tissue. So they actually get away from the rest of the biofilm because they're a little greedier than the rest of the guys, and so they invade. Okay, last one, and then I'll let you go eat lunch. Oh my God, I'm over time. I'm sorry. During a prophy, you remove supra and sub gingival biofilm. Yes or no? And if you don't, then you'll be flogged. True or false?
True.
True. Very true. Okay, and primary etiology of periodontitis. Secondary. Okay, what's all calculus lined with? And plaque hardens into. Very good. Where is calculus? Sub or supra? Both. Good luck next week.
Thank you.